What would you do if I told you there was a condition that increased pregnancy complications, increased length of stay and complications for newborns, and was a significant factor contributing to maternal mortality? I think that we would all agree that we would want to come together individually and as institutions to optimize outcomes for this patient population. Today, in the TIPQC Maternal Mortality Education Series, we will be talking about opioid use disorder in pregnancy. My name is Dr. Jessica Young. I'm an obstetrician gynecologist and an addiction medicine specialist. I also serve as the TIPQC Maternal Medical Director. I think it is so critical that we come together to talk about this topic of opioid use disorder in pregnancy because we can make a difference. We can improve outcomes. We can assist women at a place in their lives where they're struggling, and we can make a difference for their babies and their families. There are 3 key ideas that we'll be talking about today. We will be talking about opioid use disorder and substance use disorder in general. We'll be talking about how to optimize the care of opioid use disorder in pregnant and postpartum women. We will also talk about the impact of racial disparities, both on pregnancy and postpartum care in general, but also as it relates to opioid use disorder. For our first key idea, we will be understanding opioid use disorder and substance use disorder. First, we will talk about definitions of substance use disorder and opioid use disorder. We will be talking about national and regional data on opioid use disorder. And we will be discussing the impact of opioid use disorder in Tennessee on maternal mortality. So for a lot of us, substances play a role in our lives. For example, how many of you needed a cup of coffee before you came to work this morning? In order to adequately treat substance use disorder and opioid use disorder in particular, it's important to understand the definitions of the terms that we are discussing. First, substance use. What is substance use? It is the use of any substance. So that could be the consumption of alcohol, caffeine, drugs, any sort of substance. Next, substance dependence. So when someone is dependent on a substance, that means that they function normally only when that substance is present in their system. So that could be true for a lot of different substances. For example, a lot of us require caffeine to feel normal in the morning, and if we don't have it, we might have a headache or be irritable or have other side effects. Addiction or substance use disorder is a primary chronic disease of brain reward, motivation, memory, and related circuitry. So what that means is when someone is not only dependent on a substance, but also it has become problematic for them and has caused problems in their life, that's when it turns into a substance use disorder. The CDC defines opioid use disorder as a problematic pattern of opioid use that causes significant impairment or distress. When we look at national data, and this data here is from 2017 to 2018, there are several things that are striking. America has the highest drug death rate in the world. 1.7 million Americans suffer from substance use disorder related to prescription opioids. And in 2017, 47,000 Americans died from an opioid overdose. How we see this play out throughout the 90s and into the 20-teens was that there were 3 waves in the rise of opioid overdose deaths. First, we saw opioid overdose deaths primarily from prescribed drugs and increasing throughout the 2000s. And then we see in the early 2010s an increase in heroin use and a very large spike in synthetic opioids such as fentanyl. We also see this mirrored in regional trends in opioid overdoses. We see opioid overdoses increasing throughout the country and throughout different regions, with certain regions hit harder. For many regions, neonatal abstinence syndrome, which is a consequence of maternal opioid use disorder, was really the canary in the coal mine for opioid use disorder being a significant problem in various communities and regions. Neonatal abstinence syndrome is a drug withdrawal syndrome in newborns caused by the newborn developing symptoms when they are no longer exposed to the opiate that the mom has been taking during pregnancy. This condition causes prolonged hospital stays and often increases costs. A recent analysis showed that an estimated 32,000 babies were born with this syndrome in the United States in 2014, which was a more than 5-fold increase since 2004. Nationally, the rate of overdose deaths among women rose 20% in 1 year. Opioid use disorder has gone up more than 4 times among pregnant women, and there were 4 times as many infants born with neonatal abstinence syndrome in 2014 than in 1999, all illustrating what an important issue this is for both maternal and infant health. Our Tennessee data also mirrors these national trends. When we look at overdoses from opioids in Tennessee starting in 1999, we see a significant increase. We see also a significant spike in heroin as well as synthetic opioid overdoses. When we look at health conditions that contribute to maternal mortality, we see that substance use disorder also plays a significant role. Over 30% of pregnancy-associated deaths have substance use disorder as a contributing factor. Our Tennessee maternal mortality data also shows us that substance use disorder is one of the leading underlying causes of pregnancy-associated deaths in Tennessee. Acute overdose was the #1 cause of pregnancy-associated death from 2017 to 2018. This makes it imperative that we seek to improve practices that decrease overdose and decrease the other complications of substance use disorder. In Tennessee, we also see the rise of neonatal abstinence syndrome. In 2008, we had a significantly lower number of babies diagnosed with NAS after delivery. And from then on, we have seen a steady rise in the rate of neonatal abstinence syndrome among live births in Tennessee. So now that we've seen the data, both nationally and regionally, we're going to move on to how we optimize care for pregnant women with opioid use disorder. We will first be talking about patient and provider education, and most importantly, the role of stigma, how stigma prevents women from seeking care and impacts the quality of care that they receive. We'll be discussing implementation of screening, brief intervention, and referral to treatment. We'll also look at treatment guidelines. We'll look at prevention of opioid use disorder, and then resources. In Tennessee, TIPQC has a statewide opioid use disorder and pregnancy project whose goal is to optimize care for the pregnant woman with opioid use disorder and their infants. We have a bundle framework that walks through best practices from antepartum, intrapartum, and postpartum in order to optimize care for both mom and baby in all of these settings. We have created a roadmap to walk through areas that can be targeted for best practices and implementation of new guidelines. Starting in prenatal care, we optimize screening and assessment for all pregnant women using an SBIRT process. SBIRT is screening, brief intervention, and referral to treatment. We then focus on patient and family education, making sure that women with opioid use disorder and their families get the education that they need so that they are able to make the decisions that they need about their care during pregnancy, during labor, and after delivery. The next area that we focus on is management, the optimal treatment for pregnant women with opioid use disorder, and importantly, coordination with behavioral health. Focusing next on care during labor and birth, and then moving to postpartum care. This includes breastfeeding, contraception plans, and making sure that mom has linked to care. Neonatal care is an important part of this bundle as well. Discharge of the dyad is also focused on in this pathway, and then post-discharge plans for both mom and baby. This is our TIP-QC key driver diagram for opioid use disorder and pregnancy. Our primary aim is to decrease the complications of opioid use disorder during pregnancy through education, resource mapping, screening, access to treatment services, and protocols for antepartum, intrapartum, and postpartum care by December 2019. Our primary aim is to decrease the complications of opioid use disorder during pregnancy through education, resource mapping, screening, access to treatment, protocols for antepartum, intrapartum, and postpartum care. We have several bundle components lumped into readiness, recognition, response, and reporting, and several change concepts that link to each of the key determinants of the key driver diagram. By using this key driver diagram, it can help teams focus on best practices that can lead to quality improvement for pregnant women with opioid use disorder and their infants. There are several areas that we need to focus on to provide education for both patients and providers around opioid use disorder in pregnancy. Areas that we can focus on are professionalism, medical ethics, the pathophysiology of opioid use disorder in general, trauma-informed care, and how to create an environment in our clinics and hospitals that is free of stigma around substance use disorder. It is critical that we reframe opioid use disorder as a chronic medical condition, both in society at large and among medical communities. We often treat opioid use disorder as a character flaw rather than the chronic medical condition that it is. Why do we treat addiction differently than we do other chronic conditions? If someone has the chronic disease of hypertension, we see that before they're in treatment, their hypertension is poorly controlled. While they're in treatment or taking their medication, their hypertension is adequately controlled. And then we see when people stop taking their medication and stop engaging in treatment, their hypertension returns. Is addiction treatment any different? No, we see the same thing with addiction treatment. We see that prior to seeking care, patients have problems with their addiction in their lives. While they're in treatment, their opioid use disorder is managed, and then when they stop getting treatment, their opioid use disorder becomes a problem again. We need to stop thinking of relapse as a treatment failure. Opioid use disorder is not dissimilar to other chronic conditions like type 1 diabetes, hypertension, or asthma, where we see significant relapses or exacerbations of conditions in all of those diseases, and we wouldn't consider that a failure or a moral flaw on the part of that patient. Substance use disorder starts in a number of ways. For many people, especially for women, opioid use disorder starts initially as a prescribed drug. This can be prescribed for a surgery, an injury, a car accident, dental procedures. And often what we find is that when women are initially prescribed this medication, they find that not only it treats their pain, but it also helps them feel better. It elevates their mood, it takes away stress, and ultimately makes their day easier. Opioids often also cause a euphoria when taken, and that can encourage people to continue their use. For some people, it starts recreationally, with many of these drugs available in the communities. That might be the first time someone is exposed to an opiate. And then there are many people who self-medicate. They self-medicate chronic pain. They self-medicate untreated depression or anxiety. Not everyone who takes an opioid will become physically or psychologically dependent on an opiate, or they won't necessarily even develop problematic use of an opioid. But a significant percentage of women who take opioids will develop a use disorder. There is also a genetic component that significantly influences whether a person will develop a substance use disorder after exposure to a drug. Genetics plays a big part in that. We think that over half of people with a substance use disorder have a genetic component that contributes to their use disorder. We also know that there are particular proteins in the brain that are stimulated for people with opioid use disorder and upregulated for patients that have a genetic predisposition to develop addiction. Many women with substance use disorder have experienced some sort of trauma in their lifetime. We know from studies that our brains change in reaction to trauma. Teens with a history of abuse are 3 times more likely to have past or current substance misuse, and 80% of women with addiction have experienced trauma in their lifetime. That can be sexual abuse, it can be physical abuse, it can be witnessing a traumatic event. 50 to 60% of women with addiction meet criteria for PTSD, post-traumatic stress disorder, and we know that self-medication is often what many women are striving for when they initially start use of opiates. Why don't more women seek treatment for opioid use disorder? Many pregnant women feel ashamed about their addiction and fear bringing that information to their providers. Well, we think stigma plays a big role in that. It is hard for people to seek care or treatment when they feel ashamed of the situation that they're in. So the more that we can destigmatize opioid use disorder and help women feel comfortable admitting that they have a problem and asking for help, the more that we are going to see people engage in their own care. There are many factors that contribute to stigma, both on a societal and an individual level. Opioid use disorder is often overshadowed by a misconception as a moral weakness or a willful choice instead of being a medical illness. For a long time, as a society, we have separated opioid use disorder treatment from the rest of healthcare, further stigmatizing the condition. The language that we use reflects and perpetuates the stigma of opioid use disorder and its treatment. And importantly, the criminal justice system and child protective services often fail to defer to medical judgment in treatment plans for opioid use disorder. So what we say in medical care is important. Language can significantly contribute to stigma around substance use disorder and opioid use disorder. A study by 600 doctoral level clinicians showed that the way a patient was described affected the kind of treatment that clinicians wanted to give the patient. For example, if the patient was described as a substance abuser, clinicians said that the person needed punishment, chose to not self-regulate, could control their drug use, and was a social threat. With the simple change of labeling from a substance abuser to a substance use disorder, clinicians remarked that the person needed treatment, that the drug use was out of their control and not their fault, and that it was a problem that they needed help with. This illustrates the importance of language, both among ourselves as medical professionals and within the chart. There are words that we commonly use in society that stigmatize addiction. We call people addicts, abusers, and junkies. We say that their use of drugs is abuse. We describe their drug tests as clean versus dirty. We talk about their habits. We often say that their treatment is replacement or substitution therapy. They can be called a user. And then for our infants affected by neonatal abstinence syndrome, often we say that they are born addicted. All of these terms are stigmatizing, and we have better choices. Choices that center the person and frame their opioid use disorder as the medical condition it is. For example, instead of saying addict, we can say they are a person in active addiction or a person with substance use disorder. This focuses the language on them as a person first, rather than their disease first. We can describe their use of drugs as misuse, problem use, or risky use. For their drug screens, we can say the drug screens are negative or positive or substance-free, rather than using the derogatory language of dirty. We can use the correct medical terminology of substance use disorder or opioid use disorder. For treatment, we can use the correct name, which is medication-assisted treatment. And for our opioid-exposed newborns, instead of saying that they are born addicted, we describe them as an opioid-exposed newborn or an infant with NAS, neonatal abstinence syndrome. In order to adequately treat our patients with opioid use disorder, we need to know what resources are available. If we're going to be identifying patients with substance use disorder, we need to have referrals for a number of different resources and be able to get them adequate treatment. In whatever region you are in, there are numerous resources for pregnant women with substance use disorder. This ranges from outpatient to inpatient and residential programs. It is important to know where your patients can go for inpatient treatment and which residential programs welcome pregnant women and have women-centered programming. It is also critical to know which residential treatment programs allow children and which sober living and recovery housing allow children and allow medication-assisted treatment to be administered in their housing. When we're talking about outpatient programs, it's important to know about your regional resources for outpatient treatment programs for both buprenorphine and methadone, intensive outpatient programs, psychotherapy, programs for trauma-informed care and recovery support, case management resources that are available through insurance, as well as peer support groups such as NA and AA and Celebrate Recovery. I would also like to direct you to the tn.gov website that has a list of Tennessee women and pregnant women's substance abuse programs by region. In Tennessee, we also have some statewide resources. That includes the Red Line, which is a toll-free number for both patients and providers to get linked to resources in their community. There is also a list of resources on the Tennessee Department of Mental Health and Substance Abuse Services. Aunt Bertha is also an app that patients can use to link themselves to programs in their area. So what's the first step clinically for taking care of pregnant women with opioid use disorder? First, we need to be able to identify them. The recommended process for identification of substance use disorder is SBIRT: screening, brief intervention, and referral to treatment. Universal screening for drug and alcohol use in all pregnant women is recommended by ACOG and is standard of care. So who do we screen? We screen every patient, regardless of insurance status, race, or other factors. When do we screen them? We should screen them at their first prenatal visit and then upon delivery. And the reason why delivery is important is that many women deliver at a different hospital than they may have received their prenatal care or been linked to care. What do we use? It is recommended that we use a validated screening tool. An example of a validated screening tool is the 5-Piece Plus, the Craft, the Audit C, or the NIDA Quick Screen. What do we do when a woman screens positive with the validated screening tool? Well, then we do the brief intervention and referral to treatment. The 5-Piece screening tool is an example of a validated screening tool that is used to screen for substance use disorder in pregnancy. It is 5 questions. 1, did any of your parents have problems with alcohol or drug use? Peers, do any of your friends or peers have problems with alcohol or drug use? Partner, does your partner have a problem with alcohol or drug use? Past, before you were pregnant, did you have problems with alcohol or drug use? And present, in the past month, did you drink beer, wine, liquor, or use other drugs? The Institute for Health and Recovery also have developed an integrated screening tool that walks clinicians through what to do if there is a yes answer to any of those 5 questions. A lot of people ask about routine urine drug testing. Is that considered a screen for substance use disorder in pregnancy? The answer to that is no. Urine drug testing is not a screening tool, and it is not recommended to be used as screening. Urine drug testing should only be performed with patient consent and in compliance with state laws. And that is because there are implications to positive drug tests. An implication of a positive test should be reviewed, and that should be discussed in relationship to the state laws for reporting for a positive test. There are risks of false positive and false negative tests. There are commonly prescribed and over-the-counter drugs that can cause false positives on urine drug tests. Therefore, it is very important that any positive test gets sent for confirmatory testing. False negative tests are also common. There are many drugs of misuse that have short half-lives and may not test positive if a person has not taken that substance recently. This is an example of a process map for SBIRT at an initial OB visit. It shows the process that the patient would experience from arrival to clinic to the initial intake, all the way through to a potential positive screen and how the provider can interact with the patient. If a patient screens negative using the screening, they would have a warm handoff to the provider, and then the prenatal visit would begin, and a brief intervention and referral to treatment would not be indicated. If a patient screens positive on the validated screening tool, there would again be a warm handoff to the provider by the support staff. The provider would ask follow-up questions, and that would lead to a brief intervention by provider. Depending on the answers to the questions, the provider would determine substance use severity and then either refer the patient for addiction treatment or refer the patient for behavioral health and counseling. If only occasional use is elicited, the patient then would continue with routine prenatal care education, and the provider would encourage abstinence. So what is a brief intervention? Well, the key to a brief intervention is for it to be brief. It needs to be no longer than 5 to 15 minutes. And it is designed to be incorporated into a busy primary care or obstetrics practice. A brief intervention should help the patient outline their goals and identify what the next steps for the patient should be. Brief interventions are evidence-based, and they were initially developed around tobacco cessation, and a lot of the literature and research has been done around alcohol use, but it is commonly used in practice for all substances. So how do you determine what kind of treatment a patient needs? There are a couple of different ways, And that's going to depend on the substance that is used, the amount that's being used, so the severity of their use, how their use is impacting their life. Are they having legal problems, financial problems? Are they having physical withdrawal symptoms? All of that is going to go into determining severity. The severity of their use is going to determine what they're eligible for. That could be outpatient treatment, it could be an intensive outpatient program, or it could be a higher level of care like a residential treatment program. You can start this initial evaluation in your clinic to determine the level of severity, or the patient can be referred to an addiction treatment program or an addiction medicine specialist for a further evaluation and determination of next steps. It is recommended that we establish a plan of safe care for the outpatient, prenatal, and antepartum management of women who screen positive. There are a number of example protocols, best practice recommendations, and checklists that are available to be adapted. This includes safehealthcareforeverywoman.org through the AIM organization. There are a number of states also through their perinatal quality collaboratives who have toolkits and examples of checklists for pregnant women with substance use disorder. For the actual treatment of opioid use disorder during pregnancy, there are a couple of different pathways that can be utilized. A woman can be cared for within their prenatal practice and have addiction treatment integrated with their prenatal care. And that has been shown to actually improve outcomes if that can be managed. Probably more commonly, though, is to have a collaborative relationship between the primary OBGYN and an addiction medicine specialist. This collaborative relationship is very important in order to make handoffs, establish plans of care, and to make sure that the patient is accessing the level of treatment that they need. Having a team of providers that is on a patient's care team is also very important. That can include OBGYN, psychiatry, addiction medicine, anesthesiology, and even pediatrics to have prenatal consultations regarding the risk of neonatal abstinence syndrome and treatment plans for the observation for the opioid-exposed newborn and potential treatment for neonatal abstinence syndrome. Regardless of the treatment model, having a therapeutic alliance with the patient is critical. The patient needs to feel valued and to feel comfortable coming to your practice. In order to create a therapeutic environment for the patient, it is also important to educate ancillary staff so that from the first moment the patient walks into clinic, she is welcomed and made feel comfortable. So that includes educating and providing training on stigma from your front staff all the way to your nurses and anybody interacting with the patient, even over the phone. Next, we're going to move into treatment options. The first treatment option we're going to talk about for opioid use disorder is methadone maintenance therapy. Methadone maintenance therapy has been the gold standard of treatment for opioid use disorder in pregnancy for decades, since the 70s, really. Methadone is a long-acting opioid. It keeps opioid levels stable so that a woman isn't having cravings or going through withdrawal. It helps break that cycle of euphoria and withdrawal, or intoxication and withdrawal. Methadone can be only administered for addiction at a licensed methadone treatment facility and often requires daily dosing initially until a patient is well established at that treatment facility. What we do know about methadone is that it has shown improved outcomes compared to no treatment at all during pregnancy for opioid use disorder. Women who are engaged in methadone maintenance get more prenatal care and have a lower risk of complications from opioid use disorder compared to people that are not in treatment at all. They also have a decreased risk of foster care placement for their newborns because of their engagement in care. There are some disadvantages to methadone. Because it is so highly regulated and can only be dispensed from a licensed methadone treatment clinic, methadone may not be accessible if there's not a methadone treatment facility in a woman's community. For example, in the state of Tennessee, there is a limited number of methadone treatment clinics that are primarily located in major metropolitan areas. Another disadvantage can be cost. Depending on insurance coverage and area of the country, sometimes methadone may not be covered by insurance. Methadone also requires a daily visit to a clinic. This may be burdensome for a woman if they have childcare or job constraints, and in particular, if they have to travel long distances to the clinic. For women on methadone maintenance, the incidence of neonatal abstinence syndrome is about 50%. This is a reduction compared to women who are not in treatment at all, whose rate is about 70%. However, a 50% rate is still significant. A second treatment option for opioid use disorder in pregnancy is buprenorphine maintenance therapy. Buprenorphine is a partial mu opioid agonist and a full kappa opioid agonist. What this means is that it partially activates the opioid receptor, but it does not activate it as fully as a full opioid. The MOTHER trial, which was an important randomized controlled trial comparing buprenorphine to methadone, showed neonatal outcomes similar to methadone. It also showed less severe neonatal abstinence syndrome with shorter hospitalization and less morphine requirement. A significant advantage to buprenorphine maintenance is that it's an office-based treatment. This increases accessibility of buprenorphine to many communities, including rural communities. It is also dispensed by pharmacies in general, and so does not require a daily visit to a treatment facility. In general, there's more insurance coverage for buprenorphine, and many women will anecdotally tell providers that being on buprenorphine feels less like being on something because it doesn't activate those receptors in the same way as a full opioid. There are disadvantages. There are no rigorous studies on initiation during pregnancy. And unfortunately, it is often not effective for women using high doses of IV opiates, and in particular, fentanyl. It did have a higher dropout rate than methadone in the MOTHER trial, and subsequently has a higher relapse rate compared to methadone. A barrier for buprenorphine is that physicians must obtain a waiver to write prescriptions. And when we look at neonatal abstinence syndrome treatment rates, they range from 20 to 45%. So we've talked about medication-assisted treatment with methadone and buprenorphine. What about detox? What about medically assisted withdrawal? This is something that for decades we said could not happen in pregnancy due to potential risk of stillbirth. But now with studies that have come out, we have discovered that this can be an option for certain patient populations. So what are the benefits of medically assisted withdrawal? If successful, it can significantly reduce the risk of neonatal abstinence syndrome. Theoretically, it would reduce the long-term effects of opioid exposure on the fetus. It can decrease the risk of child protective services and legal action if it's successful. And it may be more supported by family and community, depending on how supported medication-assisted treatment is within a particular community. There are some disadvantages of medically assisted withdrawal. Ultimately, it is a treatment of a chronic disease with a short-term intervention. And so without being in a significant behavioral health program, there could be a significant risk of relapse and a risk of overdose. There is a lack of evidence-based protocols on how to do medically assisted withdrawal, and critically, there is a shortage of residential programs. And we know that for people who go through medically assisted withdrawal, they do better if they are in a residential program rather than discharged back to the community where their friends and family members may be using or they may be in a stressful environment. There is also a significant risk of withdrawal symptoms without appropriate medical supervision. Ultimately, education and counseling around treatment options should be patient-centered and focused and should honor a patient's desires and goals for their personal recovery. Developing an intrapartum plan of care is also important to the care for the opioid use disorder patient. There are example protocols, best practice recommendations, and checklists, again, available on the AIM website and through other perinatal quality collaboratives. These include clinical pathways for treatment of the opioid use disorder patient, checklists for the care of the pregnant woman with substance use disorder, both intrapartum and postpartum. When developing a postpartum plan of care, the focus areas are inpatient and discharge planning. Development of pain control protocols is very important. As for this patient population, they may have hypersensitivity to pain, as well as an increased tolerance to opioid medications. Having social services consults can be very helpful in an inpatient setting, and having a behavioral health consult if that is also available. Having a warm handoff from the inpatient team to outpatient providers, but also a warm handoff to the neonatal providers is critical. Developing a plan of safe care for mom and baby for discharge, and providing mom with overdose education and provision of naloxone. This is a really critical time to link them to services if they are not already in treatment, and to provide contraceptive access, including inpatient LARC if desired. When we talk about discharge planning, we want to ensure that they have an appointment with an addiction medicine specialist within 1 to 2 weeks of discharge if that is not already scheduled. This also includes a warm handoff to the outpatient providers if those aren't the same people that are doing their inpatient care. Discharging them with the plan of safe care for mom and baby. And then there's some critical education to give to patients. One is education on postpartum mood and anxiety disorders, educating them on contraceptive options and plans, providing education and referrals for home health agencies, as well as our Tennessee Early Intervention Services, and then actually giving them a Narcan prescription or a kit to go home with for overdose prevention. Contraception is an important aspect of postpartum care for all women. But we do know in this patient population of women with opioid use disorder, their risk for unintended pregnancy is higher than the general population. Counseling and education on contraception can and should be performed prenatally, and then that choice confirmed and plan readdressed during the intrapartum and postpartum stay in the hospital. Any conversation around contraception should be patient-centered and focused and non-coercive. For hospitals that care for women with opioid use disorder during pregnancy and postpartum, having protocols in place for screening for neonatal abstinence syndrome is very important. Please see the other TIPQC presentation on care of the opioid-exposed newborn for more details. For women with opioid use disorder, breastfeeding can and should be encouraged. The only exception to that would be a woman who has continued illicit drug use. For women who are stable on methadone or buprenorphine medication-assisted treatment, they can breastfeed safely. There are some barriers to optimizing care. For both the mom with opioid use disorder and the infant, there is stigma on both sides. A barrier to maternal care is identification, so screening not being done to identify these women. Another barrier to excellent care of opioid use disorder and pregnancy is pre-pregnancy insurance status. Many women, unfortunately, do not have insurance prior to becoming pregnant, which limits their ability to seek treatment before conception. Some women lose their insurance after pregnancy, and this can inhibit their ability to stay in treatment. There also can be arbitrary prescribing limits for buprenorphine that can make it difficult for pregnant women to stay on their medication-assisted treatment. Due to maternal physiology, pregnant women may need higher doses of buprenorphine than are standardly prescribed to the non-pregnant population. As a culture, we often have punitive rather than therapeutic interventions for substance use disorder, and that can make it difficult for patients to access treatment. In general, we have limited access to a number of specialties and treatment options. There are not enough addiction medicine specialists. It is difficult for people to access all levels of addiction care, including residential treatment. We have access issues to behavioral health and psychiatry treatment. And then in terms of the social determinants of health, transportation, housing, legal issues, and even dental issues can all negatively impact someone's path to recovery. Besides stigma, barriers for the infant may be rooming in. A lot of hospitals are unable to accommodate keeping mom and baby together for the length of the infant's observation and potential treatment. We know we have room for improvement in both the follow-up and surveillance needed for infants that are exposed to hepatitis C. There is developmental follow-up that is needed for the opioid-exposed newborn that may not always be accessed or accessible. Engagement in early intervention services may be limited. All of these opioid-exposed newborns qualify for early intervention services, but their families may not be able to engage in those services, and there may be stigma around engaging in those services as well. And then finally, having non-standardized plans of safe care can make it difficult for moms and babies to stay together postpartum. The third key idea that I'm going to discuss is the impact of racial disparities on the treatment of pregnant women with opioid use disorder. Are there differences in the use of methadone or buprenorphine for the treatment of opioid use disorder by race and ethnicity? Research from Dr. Schiff at Harvard showed that there are significant racial and ethnic disparities that exist in the use of medication to treat opioid use disorder in pregnancy in the state of Massachusetts. What this study showed was that Black, non-Hispanic women and Hispanic women were 58 to 63% less likely to receive any medications to treat opioid use disorder compared to white, non-Hispanic women in pregnancy. The study also showed that Black, non-Hispanic women and Hispanic women were 66 to 76% less likely to consistently receive medication to treat opioid use disorder compared to their white counterparts. The use of medications such as methadone or buprenorphine for the treatment of opioid use disorder is associated with improved outcomes for mothers and infants. Therefore, if only half of all pregnant women with opioid use disorder receive the recommended evidence-based medications, that is a problem. We know that racial and ethnic disparities lead to severe maternal morbidity and mortality. And we know that for other conditions, not just for opioid use disorder. We see that with hypertension, diabetes, obesity, depression, and other pregnancy complications. What we see is that preconception care, antenatal care, delivery and hospital care, and postpartum care all work together and contribute to the disparities that we see in severe maternal morbidity and mortality. There are patient factors that come into play, including sociodemographics, education, poverty, insurance, patient knowledge, beliefs, and health behaviors, as well as psychosocial issues like self-efficacy and social support. There are also community and neighborhood factors, the patient's social network, the neighborhood they live in, crime, poverty, built environment, and housing. Another factor that we are starting to understand the importance of is provider factors. Providers having up-to-date knowledge, experience, understanding their own implicit bias, having cultural competence, and being able to communicate effectively and empathetically with patients is critical to improving these disparities. And then we have system factors. having access to high-quality care, transportation, fighting against structural racism, and policies that promote racial disparities. It's not only access to evidence-based treatment for opioid use disorder that non-Hispanic Black women may have disparities with. We also know that non-Hispanic Black women also are less likely to receive adequate postpartum care. And we know that maternal mortality is increased during the postpartum period. Quality intraconception care may help to close some of these gaps. In conclusion, there's a lot that we can do to improve care for pregnant women with opioid use disorder prenatally, in the hospital, and postpartum. By working together, working within our institutions, and as a society, we can support women in their recovery, and we can improve outcomes for moms and babies.